Hello and welcome to SADS Live, and happy Friday to all of our SADS family out there. Obviously, we have a little switch up today, and I'm not Dr. Ackerman, but I am Jenifer Berko with the SADS Foundation. I'm the Community Engagement Coordinator, and I feel so honored to be with all of you today. I have a guest with me today, and I know you're going to be excited to hear from her. Her name is Sara Cherny, and she is a genetic counselor of cardiology at Lurie Children's Hospital in Chicago. So if you attended our conference recently, then you will have met her possibly and seen her lecture. And then she's also an assistant professor of pediatrics, and that's over at Northwestern University Feinberg School of Medicine. And I'm not done yet. She also is part of SADS Resources. So for us at SADS, she's a genetic counselor who works with SADS families, and we're just so lucky to have her today. I know you're going to enjoy her as much as we do. And so, Sara, I'd love to bring you on and welcome you to our SADS Live.
Thank you so much, Jenifer. It's really nice to be here, and I'm looking forward to talking about genetics and SADS conditions.
Me too. There's so much to get to. And I want to remind everybody who's watching that if you would like to ask Sara a question as we're having this conversation about genetics and genetic testing, that you can go ahead and comment and let us know what your questions are. And we'll be sure to try and get to them throughout this time. So, Sara, first of all, tell me a little bit about yourself, how you got involved in genetic counseling.
So I actually discovered genetic counseling by accident. I was at one of those very nerdy summer camps for marine biology because I think every teenager at some point wants to be a marine biologist. And I learned about genetic counseling kind of randomly. And it really spoke to me because it's a combination of the basic science, molecular genetics, and working with people and getting an opportunity to do education as well as connecting and understanding patients who are learning more about their own health and their family.
Fantastic. I love the camp story. Every kid loves to go to science camp.
Everybody loves to go to science camp.
Okay, so tell us a little bit about what it means to be a genetic counselor. For those people watching who have never heard about this or are possibly interested, basically, what does that mean?
So genetic counselors have a number of subspecialties. I work in just cardiology, but our basic tasks, our role is the same. Our goal is to work with families who are either at risk for genetic conditions or who have been diagnosed with a genetic condition. A lot of our time is spent doing patient education, helping families or individuals understand the genetic background of their own unique features or conditions, talk about the benefits and limitations of genetic testing. Do we do the testing coordination? And then an important part is results evaluation and analysis. Not all results are straightforward. Some of you may have experienced this. And then another really important part of our job is the family coordination, making sure that any person in the family who is either eligible for genetic testing or at risk for an inherited condition has the opportunity to get healthcare or seek more information or consider genetic testing for themselves. A lot of genetic counselors are also involved in research where we're looking at genetic counseling practice, we're looking at genetic conditions, and working with family organizations like the SADS Foundation in order to further the field for genetic counselors, but also mostly for genetic families and patients.
It seems like this field, as you're talking about continuing research, it seems this field is constantly changing at a really rapid rate, and it's such a positive thing for the community. Can you speak to that a bit?
So I would agree with that. I think genetics is one of the fastest moving fields in medicine right now. I think a lot of you have already heard that we are in the era of gene therapy, but it's not just the kind of big glamorous ideas about gene therapy, but also things as simply as what genes are included on a genetic test. Are we testing the same set of genes as we were 10 or 15 years ago? Are we better at gathering genetic information from our DNA? And then also just what we know, our knowledge continues to evolve. partly, like you said, from the research work that we are doing, and also simply by improving access and having more individuals, but also families who are able to access genetic counseling and genetic testing, we are learning more and more about how many people are truly affected by genetic conditions and all the kind of broad and diverse ways that genetic conditions can present.
Okay, okay. So tell us, how and why genetic testing is so important for the SADS community
Mhm.
specifically.
So one thing I want to point out is that genetic testing is not required for care for people who have a SADS type condition or an arrhythmia or an inherited arrhythmia condition, but it can be useful. So we like to think about how is it useful for the person in front of us, and then how is it useful for their family. And so how it can be useful for the person in front of us is first clarifying diagnosis. A lot of times you can make an arrhythmia diagnosis based on the clinical features that a person has. What does their ECG look like? What does their stress test look like? What are their signs, their symptoms? Are they feeling palpitations? Have they fainted? And a lot of times you can make that diagnosis on a clinical basis. But then what genetic testing can do is clarify or specify or add detail. Long QT is a great example. We have 3 common types of long QT as well as some rare types. And genetic testing is very useful in finding out kind of specifically which type of long QT a person might have. And that can guide treatment, such as which medications are best for you. Do you need a medication at all? Should we be considering more intense options like implantable devices? So that's how we think about genetics for the person in question. And then if we have a clear genetic answer for that person, then we can go and do cascade screening in the family. So like a waterfall, we go one step at a time through the family tree, and we can find folks who may be likely to have an arrhythmia or possibly have an arrhythmia in their life and be able to prevent any outcomes, right? So the whole goal of medicine in arrhythmia is to prevent major outcomes from happening, things that have happened to our families in the SADS Foundation and things that we would like to prevent from happening in the future. And so genetic counseling and testing is a great way to be preventive and act ahead of time before things happen.
I know that's why I personally feel so strongly about it. As most of you know, my family has CPVT, and we didn't find out until 4 years after my son passed away, our 10-year-old. And then our older one had a cardiac arrest. So we were in the hospital, Sarah, and he had just had this cardiac arrest, and they looked at it and said, teenagers don't just go into VFib. There's something definitely going on. And so they had, lucky for us, we were in the Texas Medical Center. So they had a whole genetics team that came in and ran genetic testing for our whole family, but of course, first our son immediately.
Mm-hmm.
I know that's not the case for every family, and especially when you're looking to do it as preventative, which trust me, I wish we would have known to do it. We could have prevented, losing our son and all that our other son went through. So for somebody who's not in an emergent situation, how do they get to that point? Say they, because it just depends where you are. I'm in an area where we have everything at our fingertips, but I know a lot of our viewers have, families that are in more remote areas. And so if they're meeting with their cardiologist and they've heard you speak today, and then they want to talk about genetic testing, how do they go about doing that?
Often the cardiologist, even if they are, in a remote area, will have a larger center that they are affiliated with, and there are often genetic counselors in those centers. So that's kind of the direct way that I would look for a genetic counselor to talk to you about your options for genetic testing. And then another way, kind of a quick and easy way to do it, is actually just to go online. So findageneticcounselor.com is the National Society Genetic Counselor sponsored site. And so genetic counselors are listed on there. And what you'll see is that many, many, many genetic counselors are available to do telemedicine visits. So as you can see, I'm sitting here in my office and I had telemedicine patients yesterday. It's really nice to be able to meet with families in their own homes. You don't have to worry about the travel, parking, and we have really expanded our telemedicine access to genetic counselors. One thing that is important is that genetic counselors are licensed by state. Many genetic counselors who do remote only jobs are licensed in multiple states. And so it won't matter what state you live in. But that might be one of the reasons you would want to pursue seeing a genetic counselor who's maybe at the major medical center that's in your state, but then you could still see them via telemedicine. And then of course, the goal of genetic counselor is to help you decide what is the right choice for you. What is the right genetic test? What is the right person to start with testing, and walk you through that process and make sure you feel confident about what the results do and don't tell you, and then help you work with your family from there.
Right. So we're going to get to questions in just a moment, but something you just said is a perfect moment for us to pause and talk about this. And what I want to talk about is, how do you ensure that you're getting the right genetic panel? Because I'm aware that there are so many different, I didn't know this previous to our experience. I thought every genetic test is equal. And then I soon found out, well, there's neurological genetic testing, there's cardiac genetic testing. And then even within those specialties, there are more specialized genetic tests. Is that correct?
That is true. And it keeps changing, right? That's I will toot again the horn of genetic counselors. Our whole job is to figure out the right person for the right test at the right time. If you do not have, like, if you're still not able to find a genetic counselor, it's fine. In general, we will choose a test that is the smallest necessary for the person, the time, and the setting. So, for example, for your son who's actively had a cardiac arrest, is in the hospital, time is of the essence. And so the goal there is to get as much information as possible, as fast as possible. And then, as you're saying now, like in comparison, maybe there's a person who's been living with long QT1, they're fine. They're not having an active hospitalization at that moment. And what we would say is that person who has the clinical diagnosis of long QT probably will find the explanation for that person on a panel test, where it's a set of genes that are known that would be associated with long QT. Sometimes we'll do a stepwise pattern where we start with a smaller test and then we'll go bigger from there. The bigger you go, the more likely you are to have uncertainty in your results. And uncertainty can be misleading. It can give you some kind of anxiety about what those uncertain results mean. And so we always want to be thoughtful about, like you had said, there's testing for neurology conditions or kidney conditions or bone or what all the other body systems. We want to make sure that we're asking the questions that relate to the person in front of us, so that we aren't gathering uncertainty in areas that are irrelevant for the care of our patient.
Okay, great. That explains it.
Actually, Jenifer, can I add one more thing?
Absolutely, always.
Thank you. So family variant testing. So one thing that's super important is that if you have a known variant in your family, there's no reason to do a big test. Most, but not all of our arrhythmia conditions are inherited in a dominant pattern. That means it only takes one change in one gene to cause the condition, and that is enough. And so if I have long QT and my sister wants to have testing for long QT, then all she needs to do is test for the variant that is present for me. And so what can happen is that you hear that someone in your family has long QT and they have a gene mutation, and then you go to your doctor or your cardiologist and say, I would like genetic testing. And you want to make sure that the result from the first person who has had testing travels through the internet into your hands. So that way you know what you're looking for. Because if you're not sure what you're looking for, then a negative result might not mean anything. You want to make sure that we know what we're seeing and then we don't see it, or we know what we're seeing and then we do see it. And then you can go on and get the care that you need.
Okay, great. Thank you for clarifying. So one of our first questions is from one of our families asking, how often should my genetic testing be repeated after my SCA or sudden cardiac arrest if the initial testing didn't show anything?
We have a rule of about 1 to 2 years that you should ask the question. And the question is there anything new for me? So you can call up your doctor or you can call up the genetic counselor who ordered that test for you and say, it's been a while, I had a negative test result. Is there anything new for me? Is there any value in updated testing? And the kinds of updates that can happen can be technology. It can be that we're better at assessing all the variants in a gene, or it could be new knowledge that there's other genes to investigate. It could be new technological approaches. Maybe you had an uncertain variant, and there's a way to assess that variant, for example, using RNA to see if that variant actually has an impact on the function of the gene. So, what I would say is if you haven't talked to your genetic counselor in a couple of years, call them up. We will be happy to hear from you. You may also get a random update from them. So updates happen in our world. Sometimes the laboratories will send us random faxes or random emails. Sometimes we will be looking at a particular question. Recently, the gene DSP has been really under a lot of study, and so we did an active look at all of our patients who had variants in that gene. Other times, there's a new paper out and it changes all of our practice. And then, of course, it really is an opportunity for you all to be empowered for your families and say, it's been a while, I haven't heard from you, and you haven't heard from me. Let's touch base.
Okay, great. We have another question, this one from Amy, and she says, I have recently been diagnosed with LQTS with a KCNQ1 gene. My family doesn't have any history of early deaths or fainting. My mom is awaiting genetic testing. Is it possible that she was the first person to have the gene mutations? Sadly, all grandparents have passed away, so we can't test them.
Yeah, that's a great question. So yes, it is certainly possible that any one person could be the first person in their family to have a genetic variant. We have a mix in the arrhythmia world where some people will have a variant inherited and some people will be the first person, and it just happened randomly. And that happens in the egg cell or the sperm cell that go to make that person. And so I'm always telling parents that there isn't anything you do or don't do during a pregnancy that causes long QT or any of the arrhythmias to happen, the inherited arrhythmias. And so in this case, yeah, it certainly could be that your mom is the first person, or it could be the other. Let me say this, your technical term for that, what you'll see as you Google about is a de novo, which is just Latin for new variant, also called spontaneous variant. And then once that variant is there, then it can be passed on. But then the other technical term for you, the other vocabulary word is variable penetrance or variable expressivity, where you can have that genetic change and then just never have any signs or symptoms of that condition, which is quite common in long QT1. There are quite a lot of people out there who have a KCNQ1, clearly arrhythmia associated genetic variant, and never have any signs or symptoms of the condition. So I'm glad to hear your mom is getting testing, even though it sounds like there was a surprise. And then that way we can just keep her safe and healthy going forward.
Yeah, I actually am the de novo in my family and didn't know until we had that genetic testing because of my son. So you just never know what you're going to find. And I think one of the things that has really enlightened a lot of our families is understanding that doing testing, say for yourself, can save other people in your family. So if you do your own testing and then you say, well, I have it, now I think you should get tested. You could save your child. You could save a parent by doing this kind of testing. And I know that that was something that really helped our family in all of this, understanding where did it start and who needs to, worry and be medicated. So thank you for going over that. So I have another question asking if you can talk a little bit about what a person should do if they get a VUS genetic testing result. Does that mean they have the condition or not? And where can they learn more about the VUS result?
Great question. First, let me say that in my practice, over half of our results have a VUS, at least one VUS on them.
And can you tell everybody what a VUS is? I have a feeling there are people who don't know.
VUS is variant of uncertain significance. Some people will call them VUSs or VUs. I think that sounds funny, and so I say VUS. No offense to all my colleagues who disagree with me. So this is actually a relatively new thing. So for you real grown-ups who had genetic testing before 2015, this is not something that ever came up. So we started, when I say we, I mean the genetics community started to realize that not all variants were created equal, a couple decades ago. And it was in 2015 that the American College of Medical Genetics was able to make a rubric, like a guideline that says, here's how we determine this variant is associated with disease and that variant is not. And then everything in the middle is uncertain. So you have to be 90% confident that you know whether that variant is or is not associated with the condition before you can bump it out of the uncertain category, which means lots of variants are in the uncertain category. So the hard part, I think, what we're supposed to do is give it no meaning. We're supposed to almost ignore it. We're supposed to say this variant is not known to be either associated with disease or benign, and therefore I cannot use it to make any clinical decisions. But I think that's very hard because
I think it's hard for the families to hear that as well.
It's hard for me
right?
to do.
Like, you're just
I
not
see these
supposed
every
to,
day.
right? So what do you
Yeah,
do with
so
that?
we come into genetic testing with a feeling, right? So you cannot separate your emotional experience of your condition, your family's condition, whether you've had trauma in your family because someone has passed away suddenly, whether you have fear about your own health, your child's health. You can't separate that from something as cut and dried as a genetic test result. And so you come into that uncertainty with whatever you had before you walked in the door. And so you might find that you feel an uncertain result is probably the answer, or that you feel that an uncertain result is probably not the answer. And I think that is the hardest thing about them. So we, as your providers, our job is to tell you as clearly and as completely as we can how we feel about the variant and be agnostic about it and tell you what is the actual information that is there. And do we think that there's enough to move it towards being associated with disease or not? And then we also sit there in that discomfort of not having an answer, of being neither reassured nor having an explanation for what is happening. And I think that's the hardest thing about them. So how you get more information about that is sometimes the laboratories, so let's say you got genetic testing without a genetic counselor, then the laboratory will tell you what their latest information is. They'll be able to say, we have another family in our population who has this variant, but they have a different condition than you do. And so that's not enough evidence to tie this variant to your condition. Or they'll say, this variant is a little more common in the population than I think would be typical for a disease-causing variant. Or they'll say, well, there was one paper published about it, but that paper only tested people of this age or this type of condition. So we are gathering data from multiple resources, such as the published literature, medical literature, databases, our own practices, and then computational tools. So like a computer who can analyze what is the likely effect of this particular change at this particular location. So we put all that data together. We use that guideline that I mentioned from the American College of Medical Genetics, and we add up the math. And if you make it, if the variant makes it, it gets classified as a pathogenic or disease-causing variant.
Okay.
And if it doesn't, then it's benign. And this is part of that conversation we had before. Every couple of years, we want to relook at those variants because our knowledge is always evolving. So I don't think I actually answered the question, which is like, what do you do? But I think the fact that my answer was so long and complex really shows you that uncertain variants can really stress you out.
Yeah.
And so I would say, in summary, rely on your clinical care when you have uncertainty. Rely on the fact that you're getting your clinical screening with your ECGs or echoes as needed and your Holters and all those things, that make sure you are feeling good about your medical provider, your cardiologist, your electrophysiologist, and really rely on the clinical care, because we don't always have a clear genetic answer. And then over time, maybe we can get that genetic answer.
Sure. Okay. Our next question comes from Cheryl. She says, as a mom of a kiddo with CPVT with the RYR2 gene, how does that happen?
Randomly.
I know I had the same question, Cheryl.
Yeah.
I was like, how did this happen to me? And like you were saying before, Sarah, about, it's nothing you did. It's not your fault. I remember our genetic counseling team sat down with us, and I remember they were almost nose to nose with me because they could see it happening all over my face, all the self-blame. And they said that you have no control over this. But speaking more to Cheryl's question, how does that happen?
So when we are creating egg cells and sperm cells, let's get like super biology for a second. Our DNA has to copy itself, right? So we have our DNA, which is our long string of code. And you remember probably from high school biology, maybe some of you are still in high school, but you should be in school right now. So ACGT are your little letters of your DNA alphabet. And your cell has like little protein machinery. And it comes along and it goes copy, 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 copy. But just the same way as if you were hand copying, you had a sentence in front of you and you were hand copying it, you might make a mistake, need to erase it and go back. But then you might not notice that you made a mistake. So the same thing happens in your cellular machinery. It'll copy along and then maybe it'll have one little error in that machinery that it doesn't catch. And then that error stays there and it goes on to make the egg cell or the sperm cell, and then that goes on to make a child. There's nothing we can do at this point with our current technology to change that. Who knows what science can do? A lot of what the gene therapies are trying to do is supplement those changes in the DNA or replace the changes in the DNA, but that doesn't speak to how they happen in the first place. That only happens when someone has already arrived, as someone is already here. And so that our DNA mechanism, our copying machinery has a little bit of an error rate. So everybody has genetic changes, actually. We all have them. It's just whether we know or not, right? And so we know, but what about all the other ones? So it's just not a perfect system.
I do want to let people know that SADS can help you get started and educated even. We have a site where you can send your doctor if they're unfamiliar with the genetic testing. So just going to sads.org, SADS.org, and there's a specific link, but we'll get you there. So just make sure that if you need extra information, you can rely on sads.org. Let's see. My daughter, says Carrie, my daughter Delaney was genetically tested in 2011. She has CPVT, RYR2. She was tested again about 2 years ago. My husband and I were only tested once in 2011. I know new tests have been developed since then. My question is, should we get retested?
This is a little bit hard to answer because I don't know your family. In general, all right, let me tell you the things that come to mind. My question is the purpose of the second test. Is the purpose of the second test because your providers didn't feel that the first answer that you got, the RYR2 variant, maybe they didn't feel that answer was sufficient to explain your child's clinical presentation and they were looking for additional findings? So that happens sometimes where we have more than one genetic cause for one person or one family. And then my second thought is, did they do the second test because the original variant was uncertain or that the classification of that variant changed and that there was doubt? So that would be my first question, is the purpose of the second test. And then my second question would be, if the variant that they found the first time was inherited from a parent, or if they thought it would be new. And then the second test, if there was no new findings on the second test, then there would be nothing to test the parents for, nothing to test you or the other parent for. So I would kind of go back to the ordering provider and just say, just remind me, what were we doing before? Will you remind me why we did that? And I'm sure that they'll be happy to get back into it with you. I think that a lot of times when you're in the room hospital settings, clinic settings are very hectic and you kind of feel rushed to get through. And so do always feel free to say, I'd like to chat again. I need a review. Or can you tell me why we did this? I think asking the question why will help it stick also in your brain, because what will happen is your family will ask you about it. And then you'll have to explain it to them as well. So I would go back and ask a little bit more detail about just what was their thought process. Can they describe their reasoning? And that will probably clarify it.
Okay. And I've noticed, and I hope all of you that are watching have noticed as well, that Sarah multiple times has talked about continuing a relationship with your genetic counselors, not being afraid to reach out and ask these kinds of questions, just to be able to keep up with all the changes in science and also for your own understanding. So I appreciate you continuously letting everybody know that, because it is difficult and scary sometimes. And I just also wanted to say hi to Carrie and Delaney. I actually interviewed them, and they have a beautiful story that everyone can check out on SADS.org. Just type into the search engine blog and you'll get to our blog page and you can find their story there. But they're a beautiful family, doing a lot for others out there. So let's see what else we have. So we have somebody asking, my genetic test came back as a VUS. Should my kids be tested for this?
Great question. Oh, these are such good questions.
They are.
I mean, clearly, all of you attendees are very engaged in this. And so I think you're really showing how much you can learn about yourselves and your families just by like participating in the community and having, like you said, like a relationship with your providers. So the guidelines are that we only test family members for a variant of uncertain significance if we think that it will change their care. So when we think about genetic testing, we think about who is this information. Is it you, the patient or family, or is it science and research in the community? And both of those parties are valid, but we want to make sure that we're being thoughtful about doing clinical genetic testing for the purpose of helping people have good healthcare that is personalized to them. So if there's a variant of uncertain significance, and it's truly uncertain, and I will not be able to figure out which way it goes, whether it's associated with condition or not, then I am unlikely to recommend genetic testing for any first-degree family members. If the conclusion is that we are suspicious about this variant, or that we are the opposite, if we feel like this variant is probably nothing, then sometimes additional testing in the family can help clarify the meaning of that variant. But in that case, the question is, are we going to be able to clarify it enough to be able to use it for your clinical care or your child's clinical care? And each case is unique. Each family is unique. What kind of presentations you have, what the actual variant it is, those are all unique. So it will depend. So of course, this answer about uncertain variants is a vague and uncertain answer. So it will depend on the variant and it will depend on your family. So what I would do is, again, go back to the ordering provider and say, will extra testing benefit me? Will it benefit my child, or will it benefit the community? And then decide if you want to participate. And if the provider says, honestly, I'm going to take care of your kid the same way, no matter what this information says, then there's no reason to do genetic testing unless you're feeling particularly generous and you want to contribute to the information at large. But I also don't want folks spending money on genetic testing that isn't going to benefit them. Some laboratories will have different policies about whether uncertain variant testing is free to the family or not. So that's something that you can investigate with your ordering provider. They can help you figure out what that story is, and then whatever is best for you. If you think that it'll be not useful information, then don't do it.
I remember you talked about this at our conference about genetic testing and the cost. And I know in general, on average, if you were paying out of pocket, it's about $250 for testing. Is that about right? Somewhere in there?
Things have changed.
Okay.
So depends on the test. I'm going to give you a huge range of numbers. Right now, today, literally today, and this could change tomorrow, The range of cost of testing is from like $100 to like $6,000.
Mm.
Right now, family variant testing, if you're only looking for one variant, couple $100. Big tests like the one you have, like the genome, or a test like an exome, thousands of dollars. Usually the panels are in between. It depends completely on which lab you're using. It depends on how much your insurance is going to cover. It depends on the type of test. What I would encourage families to do is investigate. I don't want folks to be afraid of the cost and never try or never have the conversation. Genetic counseling is not just about access to genetic testing. Genetic counseling is about what is right for your family, helping you get the knowledge and answer your questions, and then walking you through the process. We do spend a lot of time talking to insurance companies. Um, and a lot of times we get yes. A lot of times the insurance company will cover testing. And then you just think about your copays and deductibles and things like that. So it's rarely a non-issue from a financial perspective, but we are invested in keeping genetic medicine accessible. And so we're going to do what we can to make it work.
Okay, great. Thank you. I appreciate you going into more detail on that. We have a question from Lindsay who says, my son had an SCA and was found to have LQTS.
Mm-hmm.
Only a VUS was found on the KNCH2 gene.
Mm-hmm.
We have never seen a genetic counselor. Is this something we should look into for more information? No one else was tested beyond EKG. We are also new to this, only about 6 months since the sudden cardiac arrest.
Well, welcome to this community of people who have felt the way you feel.
That's right. You're not alone. You're not alone.
Yes. So I'm super glad you're here. I would say, yeah, it might be nice just to talk about what this means with a genetic counselor. So what I would say for you is see if there's someone that your ordering provider, so maybe it was in the hospital or maybe it was a cardiologist, see if there's a genetic counselor that they work with. And then if not, I would say look at findageneticcounselor.com and find someone that is either in your area or available on telemedicine for you, for your own knowledge, and find out what is this particular variant doing? Why is it uncertain? Is there anything else that could be done? And then you've got that relationship set up so that every couple of years you can check in again.
Okay, great. Let's see, another question from Carrie again, NFAT5, is that a VUS? Delaney has that one also.
You'll see from my face.
Yes.
I don't know what that means.
Neither do I.
That could be the name of a gene, but I'm going to say that because I don't know what it means, I'm going to guess that that is a gene that is not commonly associated with the conditions that we see.
Mm-hmm.
It may be that it's a new gene, like not new, because all genes are always there, but like newly recognized as associated with arrhythmia.
Mm-hmm.
I don't know.
Okay, that's okay. Sometimes we don't know. This is. Let's see. Let's go to Cheryl, who says, "How would I go about seeing the carrier? Should I reach out to a genetic counselor?"
So do you mean like if someone might have a genetic variant and not have any signs or symptoms? I think that's probably what you mean. Let's get nerdy about terminology for a second again. So carrier is when you have a variant in a gene that is associated with recessive inheritance, where you remember your Punnett squares, you have two big A's or you have two little A's. So if you have two parents, we have one big A and one little a, and then their child gets two little A's, and then that causes the condition, that is a person who has two variants and they have a recessive condition. Their parents are carriers. They have one big A and one little a. But in a dominantly inherited condition, which is most of the inherited arrhythmia conditions, all it takes is one big A and one little a. And so we use the term penetrance to describe what it means when you have a variant, but it's not causing you any problems. And so if there might be someone in your family, so previously we were saying that, like a parent was getting tested, and maybe that parent had gone through their whole life not having any signs or symptoms, then yeah, I think it's feasible to do testing to see if that person has that variant as a precaution. Not that we expect them to present with any arrhythmias or anything, but it's nice to know just in case.
Right. Okay. Thank you. Patty is asking, she says, known LQT2 variant, strong family history, clinically symptomatic for that variant. However, circumstances for surrounding cardiac episode don't match the standard criteria for that variant. What are your thoughts?
Meaning maybe there's something else going on?
I guess so.
It's possible, right? So we talked about how some people have more than one variant or more than one condition.
Mhm.
So I would go back to your diagnosing provider and just have a conversation with them and say, is this more dramatic perhaps or more complex presentation potentially due to an additional genetic cause?
Okay. That's a great place for us to stop because we are just basically out of time, but I tried to get to almost every question. So if your questions weren't answered and we didn't have time to get to you, please know that you can still go to sads.org to find out more information. And Sara Cherny, oh my goodness, she's like a star. We all need it. You have all the answers. Thank you so much for taking time out of your day, especially after conference, to be with us. We are so lucky to have you in our SADS family. Thank you.
Oh, thank you so much. My absolute pleasure. Thanks to everybody for joining us. Please do stay involved with SADS. It's a great place to get information and connection with each other.
Yes, thank you so much. Thank you everybody out there for tuning in on this fun Friday, and we'll look forward to seeing you next week. Have a great weekend, everybody.